Hey class, I wanted to get started on the third portion of the nervous tissue, the nervous system. As you recall, we covered the central nervous system and a little bit about the peripheral nervous system. This Friday, we'll complete the nervous system lectures by covering gross anatomy, but we're going to again start on the inside and work our way outside. And I'll also cover some tips for your midterm. That's this Friday. So with the last lecture, we talked about the roots leading the posterior side and the ventral side. So on the front side, we have the ventral horn, and on the back side, we have the dorsal horn. We also talked about this is gray matter, and this is white matter on the outside. And on the brain, it's actually opposite. The gray matter is on the outside, and the white matter is on the inside. And we discussed the dorsal roots and the dorsal root ganglion and the spinal nerves and how they meet together, and from the ventral side and the dorsal side on each side. And we discussed the different parts and of the central nervous system. Remember, the central nervous system consists of the brain and the spinal cord. Everything outside of the brain and spinal cord is considered peripheral nervous system. And here's a few pictures of what it looks like. It's a cross section there. And these are cells of gray matter and white matter. Here's another good picture of how they're organized and how you have your spinal nerves that come together, leaving both the ventral and the dorsal side coming together, going to both the somatic sensory and the intrinsic back muscles, somatic motor nerve knot fibers in the back, and somatic sensory nerve endings in the skin. So remember that your back side, or your posterior side, or dorsal side, takes care of things on the back and for somatic motor nerves. And on the front, we have all the muscles except the intrinsic back muscles. Okay, so everything in front. And somatic sensory nerve endings in the skin in the front. So let's go ahead and get going on nervous tissue 3. We're going to get into meninges today, talk about different layers of the skull and how things are protected. So the meninges are membranous coverings of the brain and spinal cord, and they're formed from connective tissue. See, on the outside, the hardest portion of this is the dura mater, and it's composed of dense connective tissue continuous with the periosteum of the skull. So that's the outer lining of the skull. And the dura mater that envelops the spinal cord is separated from the periosteum of the vertebra by the epidural space. So you're going to be hearing more about this epidural space, which contains thin-walled veins and loose connective tissue and adipose tissue. The dura mater is always separated from the arachnoid by a thin subdural space and the internal surface of all dura mater, as well as its external surface, and the spinal cord is covered by simple squamous epithelium of mesenchymal origin. So that's mesenchymal origin that we're talking about the embryological point of view. And as we move inside from the dura mater, we have an arachnoid level and layer. It's a layer in contact with the dura mater to its outside, and it's a system of tuberculae connecting the layer with the pia mater. Okay, so we have dura mater, then we have the arachnoid, and then we have pia mater. So from the outside in, you're going to have to know the order from the outside in or the inside out if you were asked a question about spaces and the order of these layers, the meninges. It's tested quite often, and it's tested when we talk about epidurals and hematomas within those spaces and what portion of the brain or what portion of layer is affected by certain types of bleeding. So it's important to pay attention to these layers. And the cavities between the tuberculi form the subarachnoid space, which is filled with cerebral spinal fluid and is completely separated from the subdural space. This space forms a hydraulic cushion that protects the central nervous system from trauma. So what you need to know is that this arachnoid level, again, it's the space it forms a hydraulic cushion that protects the central nervous system from trauma. The subarachnoid space communicates with the ventricles of the brain. And these ventricles that we talked about last lecture, we talked about this is where the cerebral spinal fluid is made and stored and circulated through these ventricles of the brain. And the arachnoid is composed of connective tissue devoid of blood vessels. So no blood, no bleeding there. And the same type of simple squamous epithelium that covers the dura mater covers its surfaces. And because this arachnoid has fewer tuberculi in the spinal cord, it can be more clearly distinguished from the pia mater in that area. And in some areas, this arachnoid perforates the dura mater, forming protrusions that terminate in the venous sinuses in the dura mater. And these protrusions are covered by endothelial cells of the veins, are called arachnoid villi. And their function is to have anastomosis and communication to reabsorb the cerebral spinal fluid into the blood of the venous sinuses. So it's an escape route for basically this fluid, the cerebral spinal fluid, and it needs somewhere to go, right? And so these protrusions, again, are covered by endothelial cells of the veins and are called arachnoid villi. And again, their function is to reabsorb the cerebral spinal fluid. Okay, coming down, again, we have the dura mater on the outside. And coming down from there, we have the arachnoid level, which we just covered. And now we're going down to the final layer, which is the pia mater. So the pia mater is loose connective tissue containing many blood vessels. So one thing to distinguish between pia and the other layers is lack of blood vessels, right? So as you can see here with the arachnoid, it lacks blood vessels. And here with pia mater, we have blood vessels. So there's one differentiation. Although it is located quite close to the nerve tissue, it is not in contact with nerve cells or fibers. So between the pia mater and the neural elements is a thin layer of neuroglial processes. And they're adhering firmly to the pia mater and forming a physical barrier at the periphery of the central nervous system. And this barrier separates the central nervous system from the cerebral spinal fluid. So there's some protection there. And the pia mater follows all the irregularities of the surface of the central nervous system and penetrates it to some extent along with the blood vessels. And it consists of squamous cells of mesenchymal origin, and it covers the pia mater. The blood vessels penetrate the central nervous system through tunnels covered by the pia mater and the perivascular spaces. The pia mater disappears before the blood vessels are transformed into capillaries. in the central nervous system, the blood capillaries are completely covered by expansions of the neuroglial cell processes. And with all these coverings, with the dura mater and the the hard surface and all the way down to the pia mater, we have to start talking about barriers, right? What can actually communicate and what is allowed in. So we have the blood-brain barrier, which is a functional barrier that allows much tighter control than that in most tissues over the passage of substances moving from the blood into the central nervous system tissue. So, and this is a way of protecting the neuronal microenvironment that exists in our brain and in our central nervous system. And so we need to protect that. And this comes in handy with, our pharmacology that you'll be learning about, and or if you haven't already learned about, it's quite apparent there. There's a lot of talk about it in pharmacology classes. So the main structural component of the blood-brain barrier is the capillary endothelium, in which the cells are tightly sealed, right, with well-developed occluding junctions, so preventing and show little or no communication between to just disallow things from entering. That's why they call it a barrier. So, and moreover, the basal lamina of the capillaries in most central nervous system regions is enveloped by the perivascular feet of astrocytes. We talked about astrocytes. You should know that astrocytes are within the central nervous system. And the perivascular feet of astrocytes, which further regulate passage of molecules and ions from the blood to the brain. So there you have one function of the astrocytes, and we need to know that astrocytes are within the central nervous system. And one of 4 cells, and you'll be required to name the other 3. Also, the blood-brain barrier allows the stable composition and constant balance of ions in the interstitial fluid surrounding neurons and glial cells that is required for their function, and protects these cells from potential toxins and infectious agents. So here's a picture of what the blood-brain barrier looks like. We have what's called tight junctions, right? These tight junctions actually prevent anything from entering or exiting there from the blood into the brain. So these are tightly wrapped. Then we have our endothelium and our basement membrane, and then our astrocytes that we talked about on the previous slides line that up between the other side of the basement membrane. We have our astrocytes. Again, the astrocytes are within the central nervous system. We touched a little bit on the choroid plexus, and the choroid plexus is a highly specialized tissue that projects as elaborate folds with many villi into the 4 large ventricles of the brain. And so it is found in the roofs of the 3rd and 4th ventricles and in the parts of the walls of the 2 lateral ventricles. All regions in which the ependymal lining directly contact the pia mater. So we talked about ependymal cells. These cells exist within, again, the central nervous system. So if you can take a look at this picture, we understand that CSF is produced by the choroid plexus in the ventricles, and it flows through the cerebral aqueduct from the 3rd to the 4th ventricle, And the CSF actually flows into the subarachnoid space. So we talked about those layers. And that subarachnoid, again, is under the arachnoid space. And lateral and medial apertures also into the spinal canal that supports the spinal column, and the spinal cord goes down. And the CSF removes wastes and provide buoyancy from within the subarachnoid space. And we talked about this circulation before, this communication, this venous uh, system here involves excess cerebrospinal fluid will be absorbed by the arachnoid villi, which will drain into the superior sagittal sinus. And that's your venous um, system here. So that's your choroid plexus. And here's an example of the ependymal cells, which align this choroid plexus. Again, this is where our CSF forms, right in through here. And this is just a section of a choroid plexus and a cavity of one of the ventricles. So kind of a picture. And there's your pia mater, right in through there. That aligns this whole area. As you can see, it's the last layer, right? So if you go from the inside to outside, if you remember pad, so P for pia mater, that's your pad, and your A is your arachnoid, and then the outside would be your dura. So from inside to outside, just remember pad, and you'll understand the order of the layers from the inside out. So each villus of the choroid plexus contains a thin layer of vascularized pia mater. And we already took a look at those ependymal cells. We understand that it's within the central nervous system. And the main function of the choroid plexus is to, this is what you need to know, remove water from the blood and release it as cerebrospinal fluid. That's what you need to know about this choroid plexus, right? And the cerebrospinal fluid is clear, has low density, contains sodium and potassium and chloride ions, but very little protein. And its only cells are normally very sparse lymphocytes. It is produced continuously across the walls of the choroid plexus villi and circulates through the ventricles and central canal, from which it passes into the subarachnoid space. And this fluid completely fills the ventricles and the central canal of the spinal cord, the subarachnoid space, and the perivascular spaces. It is important for metabolism within the central nervous system and acts to absorb mechanical shocks, which is also a primary function. And what is our medical application? The term called heterocephalus is the accumulation of excessive cerebrospinal fluid within the ventricle system leading to ventricular dilation. Most cases occur as a consequence of impaired flow obstruction of CSF and also impaired resorption of CSF, which is a failure of that venous system. And only rarely is overproduction of CSF the cause of hydrocephalus, e.g. with tumors of the choroid plexus. Clinical signs with hydrocephalus occurring in infancy and before closure of the cranial sutures causes enlargement of the head, and after infancy, expansion of the ventricles and increased intracranial pressure without a change in head circumference. So that means things are getting trapped in there. There's also, when someone has a head injury if there's nowhere for that CSF to go, people get intracranial pressure. That's another medical application you need to think about. And there's certain vital signs that are indicative of increased intracranial pressure we can talk about. But for this application, let's discuss the cranial enlargement due to hydrocephalus developing before closure of the cranial sutures. As you can see, we have an enlarged area in the back, and this is due to cranial enlargement, right? And we'll go ahead and go to the next slide and show you a picture of a normal brain off to the right. As you can see, the ventricles are normally shaped here, and with hydrocephalus, we have enlarged ventricles. So this is an enlarged ventricle here. This is a cross section, and this is dilated lateral ventricle seen in a coronal section through the mid-thalamus region. So arachnoid villi provide the main pathway for absorption of CSF into the venous circulation, since there are no lymphatic vessels in the central nervous system tissue. So that's important to know. So again, the CSF circulates through the ventricles and the subarachnoid space around the central nervous system. The CSF enters the arachnoid space containing arachnoid villi, protrusions of the arachnoid into the lumen of the venous sinus. And this permeates between or through the endothelial cell lining and the venous sinus. The CSF is separated from the blood by the endothelial cell lining of the venous sinus. And it's important to note that blood does not flow from the venous sinus to the subarachnoid space. A blockage of the movement of CSF results in its accumulation, we talked about in the previous slides, in the ventricles and around the brain. This is a condition known as hydrocephalus. So you put a check mark there. You're going to need to know what hydrocephalus is. And so here's a picture of a lumbar puncture. As you can see, the spinal cord ends around the L2 level. So whenever they do lumbar punctures, to avoid hitting the spinal cord, they do a safety factor. They go down 2 spaces. It's usually between L3 and L4, where they'll inject this hollow needle into the subarachnoid space. And that way it doesn't affect the spinal cord, but they can still either draw fluid or inject medication. Also, there's no blood-brain barrier here, right? So, so think about that. And this is just my private notes from school and stuff. So, yeah, that's why they go between L3 and L4. Something to remember. So let's get into the peripheral nervous system. We've been talking on the central nervous system for some time. And now you know, based off your knowledge, all the cells within the central nervous system. You have a pretty good idea on the gross anatomy, but we'll cover that in depth on Friday. And you know a few clinical correlates, what happens within the central nervous system. You know the layers of the pia mater, the arachnoid, subarachnoid, you know the dura mater, which is the hardest on the outside. And now let's get into the peripheral nervous system. So the main components of the peripheral nervous system are the nerves, which are bundles of nerve fibers we refer to as axons, which we covered in the first lecture, surrounded by connective tissue sheaths. Also, we're going to talk about ganglia, which is a collection of nerve cell bodies outside of the central nervous system. And then we're going to talk about supporting cells, and these are Schwann cells and satellite cells. So whenever you see Schwann cells, you have to understand that they are outside of the central nervous system. So there'll be questions on that. And also with satellite cells in the ganglia. So nerves establish communication between the brain and spinal cord centers and the sense organs and effectors, which are your muscles and glands. They possess afferent and efferent fibers in relationship to the central nervous system. So whenever we're talking about afferent, efferent, we're always relating it to the center and the central nervous system. So if it's afferent, it's coming from outside into the central nervous system, and if it's efferent, it's leaving the central nervous system to the periphery. So with macroscopic appearance, they vary in size, and from the small sensory nerve supplying the skin, 1 to 2 micrometers in diameter, to the large nerve trunks in the limbs, like the sciatic, which is 2 centimeters in diameter. And as you can see over here on the right, we have a nerve right in through there. We're going to talk about the pieces of the nerve, but as you can see, it's white matter. So it's not gray matter, it's white. And so that might paint a better picture for you between gray and white matter. They all have connective tissue sheaths and have a white or creamy color due to the myelin. So again, you should not be confused that the brain and the spinal cord are the central nervous system. Everything outside of it involving the nervous system is the peripheral nervous system. So don't worry so much about the microscopic. This is just for your knowledge, but the individual nerve fibers, the axons, become grouped together into bundles called fasciculi or fascicles. And fasciculi become grouped together to form whole nerves. And the coverings of the nerves, we talked about the myelinated axon is covered by the endoneurium, and each bundle of axons, the fasciculus, is covered by the perineurium. Each whole nerve is covered by the epineurium. So how's it organized? So the formation of nerves by grouping of nerve fibers into bundles. So enclosed, the enclosure of axons and Schwann cells within layers of connective tissue. The very deep layer, we have the endoneurium. So that's the deepest layer, as you can see right here. This is your endoneurium right there. And then we have our perineurium, right, which is this outer sheath. And then on the outside, we have our superficial layer, which is the epineurium. And that's how it's organized. So immediately around the external lamina of the Schwann cells are the association with individual nerve fibers. The reticulin fibers produced by the Schwann cells are scattered fibroblasts and capillaries in the endoneurium. So don't worry too much about this. You won't be tested on this. It's just for your knowledge. But just understand how the peripheral nervous system and the nerves are organized, understand what their layers are, and understand how those are organized. The perineurium is an enclosing sleeve of nerve fascicles. It's a bundle of groups of axons with Schwann cells and endoneurium. The sheath of unique connective tissue cells. And it's a union of cells by tight junctions. We discussed tight junctions in the past. And contractile cells with numerous actin microfilaments. So the formation of barrier to passage of macromolecules into fascicles. And then we have the blood-nerve barrier, for maintenance of the microenvironment of the nerve fibers. And this is what it looks like. As you can see, the epineurium is annotated with E. The perineurium is surrounding this nerve fiber right in through here. And we have our nerve fiber itself, which is here. And then we have arteries and veins that are within this whole system to supply it. Epineurium is the most superficial connective tissue layer of the peripheral nerves. Consists of dense, irregular fibrous coat and enclosure of multiple fascicles. Adipose tissue and large nerve sheaths, and the presence of blood vessels supplying nerves, and a branching of vessels and penetration into the perineurium. So you're not going to have to ID again, just for your knowledge. Understand that there is an epineurium, a perineurium, and an endoneurium, and how they're organized. These are actually, again, part of your peripheral nervous system, and just understand how they're layered. So when we're talking about coverings, going back to the central nervous system, we have unmyelinated and myelinated. Within the central nervous system, there is no sheath that lie in between the glial cells, and the myelinated is the sheath of myelin, and we understand, we've been talking about that there is one of 4 cells that are responsible for the myelin within the central nervous system, and those consist of, you're going to have to know this, oligodendrocytes. In the peripheral nervous system, we have the unmyelinated, called the sheath of Schwann, and these are fine sensory fibers, postganglionic fibers of the autonomic nerve and the axons of the olfactory nerve. Then with the myelinated, we have the sheath of myelin, also known as the sheath of Schwann. And that's what you need to know about that. Just know that what's important about this slide is know about the sheath of Schwann, and know that going back to the central nervous system, that the sheath of myelin within the central nervous system is oligodendrocytes. Schwann cells. So Schwann cells envelop all nerve fibers of the peripheral nervous system and extends from their attachment to entry or exit from the spinal cord and the brain, almost to their termination. Schwann cells have a heterochromic nucleus and numerous mitochondria, microtubules, microfilaments, lysosomes, rough endoplasmic reticulum, and Golgi apparatus. An external basal lamina covers Schwann cell except where it is adjacent to the axon. And we actually talked about that. And we actually picked that out in the first lecture. So revise the first lecture, and for your homework, tell me what that is. In unmyelinated fibers of the peripheral nervous system, many axons are enveloped by a Schwann cell. We have myelination. So it's important to understand that myelin in axons of the peripheral nervous system is derived from cells called Schwann cells. Here we go again, right? It consists of the cell membrane of these cells without any intervening cytoplasm, wrapped very tightly several times around the axon like a bandage. And this could be clearly seen under the electronic microscope as alternating layers, as many as 50, of lipids and proteins wrapped spirally around the axon. This thickness of the myelin is determined by the axon diameter, the growth factor called neuroregulin NRG1, a transmembrane protein in axolema, and it acts as a signal. So it helps with signaling within the peripheral nervous system. So what's important to know about this? That Schwann cells are actually the myelination. Okay, it's derived from cells called Schwann cells. It's also important to note that these, with the presence of Schwann cells, it promotes signaling as well. So here's a picture, what it looks like and how the Schwann cell starts to wrap around a portion of an axon, and the nucleus can be found within that sheath, as you can see, right in through here. And the Schwann cell cytoplasm, the plasma membrane, begin to form consecutive layers around the axon, and eventually there's an overlapping of layers, and you have what looks like a complete wrap. Then over here, the Schwann cell and cytoplasm nucleus are pushed to the periphery of the cell as the myelin sheath is formed. So here's your Schwann cell to the outside, right? And then you have the myelin sheath that covers the axon itself. So this is completely formed here. So getting more on myelination, this is more for your knowledge. Won't be tested on the nodes of Ranvier or the Schmidt-Lantermann. Let's just go over it for your knowledge. Several Schwann cells may be required to form a complete wrapping around the axon, and there are therefore gaps. These gaps in the myelin sheath where the cytoplasm of adjacent Schwann cells meet. This gap is called the node of Ranvier, and it is important in the mechanism of transmission of the nerve impulses. And just know that the node of Ranvier is important to the mechanism of the transmission of nerve impulses, but you're not required to identify them under a microscope. One Schwann cell provides the myelin sheath for each internode. In addition to nodes of Ranvier, occasionally deep clefts can be seen passing obliquely through the myelin, and these are called the Schmidt-Lantermann clefts. So there's another picture of it. You can see the slanting of the Schmidt-Lantermann cells, and then you have on the top portion of the axon, you have the node of Ranvier. And of course, on the outside, you have the nucleus of Schwann cell, which is on the outer layer. So again, the myelin is a fatty, highly refractile sheath containing phospholipids, which gives nerves and the white matter of the brain their characteristic creamy yellow color when seen with the unaided eye. Don't worry so much about the H&E preparations, but the lipids, the myelin, are dissolved when fixed. This special fixatives and stains, osmic acid, fixes the myelin and is not extracted during processing. So the composition is 80% lipids for myelin, cholesterol, phospholipids, glycolipids, and plasmalogens, and 20% proteins and proteolipids. Myelin in central nervous system and peripheral nervous system is similar in overall protein and lipid composition. However, different proteins are found in the central nervous system and the peripheral nervous myelin. The myelin basic protein and P2 are present in both myelin of the central nervous system and the peripheral nervous system. And protein 0 and PNP22 are the proteins of the PNS myelin. Proteolipid protein is found only in the central nervous system myelin. So just understand that there's special stains and things to make them show up and what's dissolved and so forth. What's important about this slide that you need to know is that it's a fatty, highly refractile sheath containing phospholipids, right? And how it's derived, how their color is derived. So here's the unmyelinated axons up top, Schwann cell starts to envelop multiple axons, and you'll see a portion of it that's unmyelinated. And then the unmyelinated axons down below are enveloped by Schwann cell, but there are no myelin sheath wraps around each axon. So it's kind of like semi-covered, right? But not. It's important to note these diseases are going to come up within your training here at school, and these are known as demyelination diseases. They could be immune mediated, they could be inherited, they could be metabolic or virus induced. The first one, the most important one that you'll need to remember, is multiple sclerosis, which is an immune system attacks and damages the myelin. And then you have Guillain-Barré syndrome, which the peripheral nerves only, autoimmune response directed against Schwann cell membranes or axoplasm of the peripheral nerves. You'll also have adrenoleukodystrophy, which is an inherited disorder of paroxysmal fatty acid beta oxidation. And all of these have different symptoms, and also the metabolic central pontine myelinosis, which has to do with vitamin B12 deficiency. The virus-induced is a progressive multifocal encephalopathy caused by JC virus or John Cunningham virus. It's a type of human polyomavirus. A disease occurs almost exclusively in people with severe immune deficiency. The important ones that you need to remember are the top two, the multiple sclerosis and the Guillain-Barré syndrome. So again, with demyelinating diseases, the conditions are characterized by preferential damage to the myelin with relative preservation of axons. The clinical deficits are due to the effect of myelin and their loss of transmission of electrical impulses. So we discussed before that myelin is responsible for transmission, or is in addition to their covering, they also promote that transmission of electrical impulses. And this is where we have our multiple sclerosis, which is an example. Understand that multiple sclerosis is a demyelinating disease. So the loss of myelin causes loss of insulation in nerve fibers, and this results in much less efficient nerve conduction. With multiple sclerosis, you know now, based off your knowledge, that it's a demyelinating disease in which the insulating covers of the nerve cells in the brain and spinal cord are damaged. And this damage disrupts the ability of parts of the nervous system to communicate, resulting in a wide range of signs and symptoms, including physical, mental, as well as sometimes with psychiatric problems. So you may be asked a question in the near future, the difference between multiple sclerosis and Parkinson's disease. We're going to get into Parkinson's as well, but understand that MS for now is a demyelinating disease, and that it can result in a wide range of signs and symptoms. And that'll be it for today's lecture. I wanted to thank you. Don't worry too much about these questions. We'll just get going on the gross anatomy. And I'd like to show you a couple of pictures to assist you with Friday's test. And so, this in mind. So this top view of the clavicle, right? So whenever you see the top, for identification, this will help you with your ID on Friday. So this is your superior view. And understand that whenever you're looking at the top, it's smooth. Not a lot of holes or tubercles or anything on it. Very smooth. And the fat part is going to be your acromial end. And if we're looking down on the clavicle from above, your sternal end is going to be shaped like this. And this is your medial side, right? That connects to the sternum. And this is going to be what we call convex to the medial side, right? It's convex, it's away from the body, right? So this is your convex side. This is the way to ID, again, the smooth surface is the top surface, okay? Your sternal end is the thinner of the two ends. Your acromial end is essentially concave. So this is concave, and this is convex. Convex to the medial side, concave to the lateral side, and you're going to have a conoid tubercle on top, right? And that's how to identify the difference between the posterior, or pardon me, the top view and the bottom view. If you're looking at the bottom, it's going to be rougher, right? You'll still be able to identify the acromial end because it's larger, and you'll still be able to identify the sternal end because it's thinner. But it's just the opposite, the medial side. We're looking underneath this bone and looking up towards the bone, towards the clavicle. This is your view. You're going to have a concave side and then a convex side. So it'd just be the opposite of this. Okay. So depending on how you look at it, it's going to be the opposite of the top view. Okay, and to identify, to make sure that you know you're looking from the inferior side, this is going to be more rough. And also, the distinguishing sign is a nutrient foramen, which is located right here. And that's to deliver nutrients with the use of blood vessels to feed that bone. Okay, that's one side. And there's going to be some other attachment points in through here that you can see where the conoid tubercle is. There's also some trapezoid lines, and over here we have our costoclavicular ligament impression, where the costoclavicular ligament is attached to, and attaches to, makes everything come together right there at the central portion, the medial portion on the sternal end. So that's one I'd like to show you. And so again, a quick review. Remember, the inferior surface is going to be rough, right? We have the conoid tubercle and the conoid ligament, which is part of the corococlavicular ligament. You're going to have signs of that. You're also going to have the impression and also subclavian groove, which is attachment for the subclavius down through. So just remember, it's going to be rougher on this side. We already discussed the convex and concave portions of the superior view, and so you'll be able to identify both the acromial end and the sternal end as a result of that, if I give you a superior view picture. Okay, so this is a picture of our last quiz. I just wanted to go through some of this. This is what it's going to look like, but the numbers will be changed. So I just want you guys to get used to looking at this type of picture and picking out certain sutures, certain bones. And you guys, we already did a pretty good review, but I wanted to show you some other stuff to give you guys some more training. And here we go. All right. So this is what you're going to be looking at. Probably be a different number associated with it. And here we go. You might have to identify some sutures on the back, maybe some protuberances on the bottom that are very important, especially when it comes to acupuncture. We use a lot of those ridges as identification points to find points. I probably won't give you any inferior views of the skull. This is a picture there. I'll give you a question there. And I'll give you a question here. We've already did a review of the spinal ligaments. You guys, the majority of you got that right. And the different parts of the vertebra. Definitely know this. We did an assignment on it, so you should have a pretty good idea of the names of this dens here. All right. Know the difference between, if I show you two, know the difference between C1 and C2. And again, different parts of the vertebra, pieces of the vertebra, what are they? Getting into the rib cage, different aspects and parts of the sternum. And again, in the previous slide, I talked about the smooth edge and the rough edge. So, quick way to identify that in a hurry is to identify right away, this is the smooth edge, right? So now you know you're looking from the top to the bottom. And this is the rough edge, you know you're looking from to the bottom up. All right. So with here, all right, you're gonna see this, you're gonna know you're looking at, when you see this big, these fossas, the supraspinous area, right, you know you're looking from the rear to the scapula. And this is gonna be, on this side, you're gonna have, three different borders, right? You're gonna have the lateral border, right here, and the medial border, which we talked about, right? And this is going to be the anterior aspect. So this is the anterior side. If you were to look through somebody's rib cage, and this is what you would see if the ribs were removed, you would see this, lacking the muscle. And so the muscle that belongs here is going to be your subscapularis, because it's underneath the scapula. And that subscapularis is responsible for medial rotation of the shoulder. All right. So this is looking at, just like if you were to expose someone's back, okay, you're going to see this, the spine right here. and you're going to see the superior angle up top. You're going to see the inferior angle on the bottom, and your lateral angle right on the side to match that acromion right in there and the coracoid process. So these are just little cues to find out what you're actually looking at. You know, if you can see this structure that separates the infraspinatus from the supraspinatus area, you know you're looking at the posterior side, posterior aspect. You don't see that, you know you're looking at the anterior aspect of the scapula. So whenever you see this humerus, okay, if I were to look at, this is the anterior view, if someone was in the anatomical position, okay, you know this is the anterior view because you're going to have this big piece down here, you know, this whole area right in through here. And these areas here allow articulation with the radius and ulna. So I'm not going to tell you what this is now, but just study this, hard and heavy. Study it as much as you can. But I'm just giving you clues to orient it to know what you're looking at. And this piece here, right in through here, allows the olecranon, it's a dead space, right? That allows the olecranon when um, a space to go to, right? When in full flexion and extension, it allows that olecranon to actually go into that space. So now you know you're looking at the posterior side, right? So you can always identify and orient yourself if you have the head of the humerus that fits into the glenohumeral cavity in space. If it's you know that's to the medial side. Now you just need to identify which side is posterior and which side is anterior. You're going to have your greater and lesser tubercles, and this is also a way to identify your anterior view because they're not going to be quite visible on this side. You might catch a little bit of it on this side. So there's one way to orient yourself. All right. So we talked about the membranes. What's that called? You know, the ulna is actually longer than the radius. The radius is going to have that flat baseball bat looking feature on the top. We talked about the annular ligament, how you know children are injured with parents swinging them by one arm. We talked about this membrane, know the name of that membrane, and know the styloid processes of both the radius and the ulna. Whenever you have the radius, always remember the radius is always to the lateral side when in the anatomical position, and we'll refer to it as such. So all questions will be based, unless told otherwise within the question, that it'll be from the anatomical position. Okay. So we're not going to worry so much on the hand bones on this test, but for the final exam, you'll have to know both the hand bones and the foot bones. Different parts of the pelvis, certainly know that. This Friday, We already talked about the femur, different parts, the patella, you know what that is, and the tib fib. Yeah, just know different parts, know the medial side versus the lateral side, both on near the knee, the connection of the knee, and the connection of the ankle, and know what the lateral malleolus and the medial malleolus look like down towards the foot. Okay, so we're pretty much all finished. That was your peripheral nervous system lecture and a midterm review for this Friday. You've done a lot of studying. I want you to trust yourself and be confident going into this exam. You've had a couple of good reviews, and it takes a lot of study time. What I wanted to do today is just help you orient those bones so you don't make any mistakes. I know you guys did very well on the first exam without being notified, so you guys should do pretty well on this exam. So I guess I'll see you Friday, and it'll be, I want you to download and print out, or if you don't want to print it out, you can just type your answers in. And when we're done with the ID exam, you can go ahead and just put it in the chat box to me, and I'll download it from there, grade them, give you immediate feedback that evening, and we'll be done. So we have a short lecture on gross anatomy on the nervous system, and it'll be a short day, following the exam. Not going to be a long lecture. So you guys have a great week. Hope you enjoyed this knowledge of the central nervous system, the peripheral nervous system, and we have something to look forward to with the gross anatomy. So you guys have a great week. See you Friday.